The final contestants are Dr. Atul, Dr. Shruti Deep, Dr. Neeraj, Dr. Jitendra, Dr. Sanjay, Dr. Pratik, Dr. Prasanna Venkatesh, Dr. Ashish Bachav, Dr. Vivekanandan, Dr. Mudit, Dr. Sunita, and Dr. Vikas. You just confirm.
Who else has not come? Only Shruti has not come, no?
Dr. Atul, are you ready?
No, I actually want to got to get up with the name because there's some number which is listed. As she reads out, please just get up and don't mind.
Dr. Shruti,
She's not there.
Dr. Neeraj,
Talking Neeraj. Yeah.
Dr. Jitendra,
Yeah.
Dr. Sanjay,
Sanjay is not there.
Dr.
Sanjay, yes. Yeah.
Dr. Pratik,
Yeah.
Dr. Prasanna, he's not.
Prasanna is not.
Dr. Ashish,
Call Prasanna. Dr. Ashish.
he's not there. Dr.
Ashish, Prasanna, Shruti to call.
Vivekanandan is not there.
Dr. Vivekanandan is not there. This is not that.
Dr. Mudit,
He's there.
Dr. Sunita,
He's there.
Dr. Vikas,
There. So basically, you're going to call them and we are going to start with the rest. Please call them. It will become big issue.
Dr. Latu, you can.
Panel should ask questions and the judges should keep quiet.
Send an SMS and call.
Dr. Ashish,
Should ask questions.
can you present in a second? He wanted to leave.
Quiet and just put them up.
I have, you all have the scoring sheets, no? I had already shared in the Shruti comments. I did not.
Dr. Neeraj, second.
He is going to present.
Yeah, take your time. Can you make it full
Authors
screen?
have no financial interest in this presentation.
Yeah.
Presenting to you a novel, patent pending slit lamp based toric marker. There have been
Go back. Can you make it full screen? Yeah, so I'm Dr. Neeraj Israni in the list. My topic is slit lamp assisted toric marker, STORM. Can you start the video? Again, I'm Dr. Neeraj Israni. Please start the video. Volume. Please reset the timer. No, please reset the timer and start the video. You're not starting the video.
Please start the video. You don't get hassled, you relax.
Okay.
You're being judged. That International Hero Award, anyway, that award is waiting for you.
Okay.
You should get this award also.
Yeah, definitely.
various innovations in axis marking, right from the anti-stromal puncture, the pendulum marker, and the bubble marker. On the other hand, automated markers such as the Varion, the application-based marking, and the Callisto image-guided system are also there, but however, they are very expensive. Manual handheld toric markers invariably give us a picture like this, which is completely off the axis. So we had a research question. Can we actually innovate an economical, accurate, stable, and easy to use toric marker? We took inspiration from the Goldman's applanation tonometer, which goes and indents the cornea of the patient, and the patient is not hesitant at all. We decided to use the calibration slot, which is universal in every slit lamp, for our slit lamp based toric marker. This was the first hand-drawn diagram of our toric marker. We further started doing 3D printed models. As you can see, the 3D printed models became bulkier every time. Thus, we finally settled with a shaft within a shaft, that is the Ivy stand design. Now, coming to the first prototype of our device. As you can see, we have implanted it into the calibration slot of the slit lamp. With the help of the knob of the slit lamp, we move it ahead. It goes and indents the cornea at the desirable axis. Again, with the knob, we take the slit lamp behind and it comes back to its original position. Now, the final prototype consists of a dial with a shaft made out of stainless steel. The dial is rotatable 360 degrees and has an atraumatic edge. On the other hand, the adapter or the body of the toric marker is along with a plate to accommodate a levelometer called as the bullseye levelometer. This bullseye levelometer makes sure that the toric marker is perpendicular to the table of the slit lamp. Storm is now published in Indian Patent Journal and is in the final stage of hearing as long as the patent is concerned. Thanks to Epsilon USA, we have now come up with the final product. As you can see, the final product is made out of extremely lightweight aluminum and the marker is made out of titanium with very precise and sharp edges. The same procedure is done again where the marker is placed into the calibration slot. The bubble marker makes sure that the storm is perpendicular to the slit lamp table. The toric marker is then fixed using the screw as you can see, and with the help of the knob of the slit lamp, the marker can be taken ahead or behind, and as you can see, we mark the toric marker using the blue ball pen, and the eye is indented beautifully and the patient is very comfortable as seen over here. This is how the marks appear on the eye. It not only leaves a mark but also slightly indents the cornea at that particular axis.
Thank you.
Yes, Dr. Mahipal. Give him a mic.
I think Dr. Neeraj, excellent, good. I think it's, except that for every time that you have to do, you have to kind of assemble it, right?
No, so the thing is that the body can be permanently fixed on the slit lamp.
Okay.
Bubble marker also once a day if you just calibrate it. Only part is that every time you have to do it, you have to sterilize this detachable part. So sterilization can be done. You can lift it up with a chittle, put it over here, just mark the blue point, and just like application, take it and then mark the eye. So one sterilization can go on for multiple patients.
The one thing you said that these markers are sharp. Why do you need sharp?
So the thing is that they not only, so it's a slit, it's like a small slit.
No,
They
I
not
understand
only
that's
mark.
what they are.
Yeah. So normally what happens is that what I have noticed is when you put a drop of paraffin, the mark just goes away because it's just a line. So what this does is not only marks but like an anterior stromal, it slightly also indents the epithelium. So
Yeah.
even when
No, indent versus abrade.
sorry sir.
Indent versus abrading the epithelium. That's my question.
No, it doesn't abrade, but
No?
it slightly, yeah, but the mark remains there. So even if you put a blue dye on the
And
surgical
how
table.
is it to rotate the dials?
So if you see, we have put a mark over here. I'll show you.
Yeah.
And with the, so it's a 360-degree marker. You can exactly mark the precise axis also. Also, we have another attachment of a U. So those who want to only mark the reference axis, all you have to do is remove this attachment, put a similar attachment.
So would you consider an option of having 3 marks, 0, 180,
Yes.
90?
So the U has a 0, 180 degree and 90.
Has.
This has 2 marks, which is the
So you
desirable
can
axis.
interchange that.
Yes, sir. Yes.
You're making it commercially available?
Sir, it is available at the stall of Epsilon and they are taking pre-orders
Pre-order.
already.
And,
Yes, sir. Because I have got this only a week back.
Sterilization is autoclave, right? For
This you don't need to autoclave this. Yeah.
No, this is autoclave.
Yes, sir. Yes, sir.
Anyone? Thank you.
All right. Thank you.
What's the cost of it?
They're costing it approximately 18K, the entire thing.
18K. And what's your take on it? Your commercial
so
interest?
So right now I'm in talking terms with them. That's why we are taking pre-orders because the device is ready. It's also we've done studies
they
on
are
this.
much smarter than you. You should protect your rights. That's all
Definitely,
that I'm trying
sir.
to say.
I've already put that forward for a royalty.
No, one more thing. Can you put one more dial there so that you can mark the axis also, say 30 degrees, 150
Yes, sir.
degrees, whatever.
This does
Yes,
that.
it's done.
I will show you. This is a rotatable. Every 2 degree there's a mark.
So would you be saying that you just put 2 or you can go rotate and again put another one?
So it's a surgeon's choice, whatever he
then
feels
you can go
comfortable.
to rotate
There are some surgeons who feel comfortable with a reference mark only, some who want to mark the precise axis. I've done a study comparing it with Varion also.
Okay, so my question would be fine. How does it compare to the normal bubble marker that we are using?
You cannot compare with the bubble marker because
Why?
bubble marker can only mark 0, 180.
Yes, fine.
This can mark precisely every
No, no, but
axis.
that's fine.
I've done a study comparing it with the bubble marker in 25 eyes. The least deviation in axis with this was 2.07 degrees as compared to Varion, whereas
Okay.
with the bubble marker it was approximately 4.5 as compared to Varion.
Okay. Thank you.
Thank you, sir.
The next presenter is Dr. Atul, and the discussant will be Dr. Hemant.
Dr. Praveen, you are not judging? Just come. We are short of judges, all that 12
Atul
all
sir.
are not there.
Good afternoon.
So we can have a chat. I thought, are you willing?
Good afternoon, respected dignitaries and my dear colleagues. My name is Dr. Atul. Let's start with a video. So as you can see, this is a typical advanced diabetic vitrectomy case. My sir is dissecting the membrane, the fibrovascular membranes, and immediately you can see the bleeding is happening. It's bleeding from a bleeder. So now the next step is to take the cutter out and go in with a point cautery, and he's cauterizing the bleeder. So probably the bleeder was there, so you will try to cauterize it there and then further dissect it. So by the time after cauterizing, we'll take out the point cautery and then go in with the cutter. The bleeding has increased. The entire field has filled with blood. So when I was assisting on the side scope, I thought, how could I have helped my sir? Can I do something to make the situation better? Could I do something to prevent that bleeding from happening? So that's how this idea came up from. And I call this IDI, intraocular diathermy instrument, a challenge we have overcome in vitreoretinal surgery. So let's look at the existing scenario. Conventional diathermy probe is point shaped. The surgeon must push on the blood vessel and to close it and coagulate it. High energy levels are needed, sometimes causing collateral damage. Tip of the diathermy probe is blocking the surgeon's view and hence can sometimes not be exactly, can damage the underlying tissues as well. But there is always an unavoidable delay, like we saw in the video when taking one instrument out and putting the other in. So this will prevent you from doing a perfect or a good advanced diabetic vitrectomy surgery. So I thought, how can I combine a membrane peeling forceps with a diathermy? So can I give a membrane peeling forceps the ability to cauterize, to diathermize? So after some brainstorming, we wanted to combine all the ability to apply mechanical compression from both the sides, at the same time giving it diathermy function, and then peel the membrane. So all the three things happening at the same time with a single instrument. That was a plan. So with those things in mind, we wanted the material to be conductive and no heat dissipation in the shaft. So I only wanted the cautery happening at the tip where the prongs are coming in contact, not elsewhere. It should have good temper and hardness, can be operated with a foot switch or handle switch. For example, when I hold the membrane, I don't want the cautery happening every time I hold it. So I will have a foot switch which will control the cautery. So with that idea in mind, Chennai Surgicals helped me develop the first prototype, which we have developed in 20 gauge. As you can see here, it comes with 2-cylinder system, an outer cylinder and an inner cylinder. The inner cylinder is connected to one pole, the one pole of the diathermy, the other one to the other pole. So, and both the cylinders are connected to the inside cylinder to one prong and the outside cylinder to the other prong. So only when the prongs come in contact, the circuit is completed and electricity passes through, and whatever tissue is in between will get cauterized. So this is the principle. So this example shows a push button mechanism. We have also developed a 360-degree pressing mechanism in just like our grease saber or the normal membrane peeling forceps we have. So now we have started already developing the 23 and 25 gauge. 20 gauge was the starting point, and now also, as you can see in the image below, we have also worked on combining the endolight with endo laser. Usually what happens is if you want to laser a part of the retina, you have to put endolight through with your left hand and the laser through the right hand if you're a right dominant, and you laser. So what if I can give endolight and endo laser in the same hand, and maybe I can indent with the other? I don't need an assistant to indent to laser the periphery, for example. So that is another thing we are working on. And we also want to add the cauterizing ability to instruments like retinal pick as well, not just the forceps. So this is the starting. We call this entire series IDI, intraocular diathermy instruments. Thank you.
Yeah, I need to comment. Yeah, good presentation. Thank
you,
you. I think you're looking, how you can make the extraocular diathermy. That what they use it as a forceps intraocular.
Intraocular.
Primarily, you're just adapting it to the intraocular use. One problem that I foresee is the tissues get accumulated on the edges. So whenever you use a diathermy, you find that the tissue gets into it and then it becomes charged and makes it ineffective. You need to take it out, clean the edges,
Yes,
and
sir.
then again put it. So this is going to be a bigger challenge that you will face
Yes, sir.
whenever you do. And generally what happens is when you see our diathermy tips are very pointed, primarily just to give you the smallest amount of cautery that you have. In a forceps, it will produce a larger cautery burn, which
So,
I think is not the right
so the
way
forceps, actually, we have these end grasping forceps.
Correct.
So if we give it in the end grasping forceps, only the end will have the cauterizing ability. So our aim is to the large scale aim is to give the ability of cauterization to most of the instruments that we use. So what the surgeon wants to use can be up to him. So probably if the end grasping is used, only the tip, like you said, sir, only that will come in contact, avoiding collateral damage. Only the tissue in between will get cauterized. And the point you said about tissue getting charred is a point that we have to consider.
You have to take care of
Maybe
that.
we can find some breakthrough in that as well. But the work is progressing well, and we are hopeful that by the next time the 25 gauge will be available in the market.
No, very good thought. But another thought that you can look at if you are able to adapt is do get just 2 terminals to connect to the endoilluminator and the cutter and give you cautery.
So we thought about that, but the problem is at that time we will have to bring the endolight close to the tissue and the cutter close to the tissue.
To get the
so
to
the
get the two
vision will
terminals
the light will go off if you bring it close to the retina.
So that's there.
So that we tried that also.
Good.
We tried a lot of things.
Thank you, Pa.
Thank you.
Thank you, doctor. And the next presenter will be Dr. Shruti Deep, and the discussant will be Dr. Satyamurthy.
Good afternoon, everyone. So I will be presenting my work. So imagine such a beautiful scenery that is happening right here in front of your eyes. And now imagine if you're going to be seeing the same scene like this. Now imagine 50% of the world that is going to be seeing the scene like that. And that is myopia, the inconvenient truth that we are going to be seeing. And globally, we're going to be seeing almost 1 out of 2 kids suffering from that kind of a vision disturbance. And it's not just across the globe. Even in India, we're going to have postulated 50% of our population, Indians, developing myopia in the future. Now, against a background like this, the problem is difficult, but the solution is simple, and it's sunlight. There are several studies on sunlight that talk about the protective effect on sunlight against the prevention and progression of myopia. But the difficulties are that we still don't know what exactly it is in the sunlight. Is it the outdoors or the distance viewing, or what is it? And our questionnaire is the only way. Like they have a very poor recall value, and parents don't work full day anyway. So how can we also promote outdoor activity to parent and child? To answer all these questions, we came up with an innovative solution called the Lumino Sundial, which is a wearable light tracker. And this tracker can be worn on the wrist of the child or can be attached to the ID card of the child. And it is a dynamic monitor of the child's outdoor activity. Now, it has an ambient light sensor on the top and a heart rate sensor and a toggle on the side. The data that we can harvest is quite rich. We can have the illuminance levels through the luxometer, through a UV exposure using a UV index, infrared exposure, the physical activity using an accelerometer, heart rate, the ambient temperature that the child is in, and putting all these parameters together, we calculate the overall outdoors time. Now, through this device, it works through an ambient light sensor that calculates one reading every 5 seconds and computes it together for 1 hour, 60 readings. So the child is actively, dynamically monitored, and all of this can be synced to a mobile phone application that the parent as well as the doctor is able to see. It has a dashboard where they have a dynamic monitoring of how much 24-hour sunlight is, and the parent also gets to set goals as to how much exposure the child would require. The first step was already presented last time. We validated it against a standard luxometer with the reliability of 0.786. We then went ahead now to put it in 4 different settings, which is sunlight, shade, indoor natural illumination near a window, and indoor artificial light. We found that there is statistically significant difference when the device is placed in each of these conditions. And what is more important is we found that ultraviolet light was found to be a much more sensitive predictor of outdoors than luxometer itself. So going beyond this, we also found that some interesting thing, though 1000 lux is taken arbitrarily as outdoors, we found that in some situations of outdoor shade it was less than 1000, and sometimes in natural illumination it was more than 1000. So what we did, we wanted real data, so we put in all the data that we exposed the device and the children to into machine learning, and then we calculated the using a Python software, and found that the device had an accuracy of 67%. We also did a wearability and compliance study for 1 week. Children were extremely happy with the device, and the average time spent outdoors for them over school days was 38 minutes, and over holidays was 1.2 hours. We also did a 3-month long study which we have done, and you can see that if you focus in the indoor and the outdoor exposure, you can see the UV was much lesser in the indoor as compared to the outdoor, and the visible light was 41 as compared to 110. So the learnings from this is UV is a better predictor. Standing near a window actually provides similar sunlight exposure as moving outdoors under a canopy, and children actually have a good feedback mechanism from this device. So now we are currently studying this device with the Erasmus Rotterdam group and to see how tropical and temperate regions fare in terms of sunlight exposure. So to put it in a nutshell, this is a reliable measurement of sunlight exposure. It's a pivotal research tool that the clinician can have, and it's also a way for customized myopia control because the doctor gets to see how much exposure the child has, and for the parent and child it's a good feedback mechanism. These are my references. This is me when I was a child, and these are my children today. So I think we have to change the way we look at near work and outdoors. Thank you so much.
Thank you so much.
Thank you.
Dr. Shruti, very nice presentation. No, how many children you have followed? Like?
So we have given to 20 children, sir. 20 children. We have studied for 3 months now, and now what we have done is taken, because I have limited number of devices because they are prototypes, I have given 10 of my devices to the Rotterdam group in Europe. So we are going to study different 10 set of children there and here.
So in 3 months,
yes,
what is the what are the results like?
So as of now, what we had done was we had taken 10 children who were non-myopes versus 10 children who were myopes, and interestingly, we found out that the myopes actually had lesser outdoor time as compared to the non-myopes. But this was without giving them any lifestyle change, because we didn't want to create a bias in the first place when we handed out. But because of the factor of ethics, we cannot restrain for too long. So after 3 months, I had to inform that group of people to spend more time outdoors. Yes. No, ma'am.
There's already an existing device for
Yes, ma'am. So that is a MyLight tracker. I am aware of that, and we developed it parallelly.
How is yours different?
Yes, ma'am. So MyLight tracker is primarily a luxometer. It's a portable lux which can be worn. So it's a light tracker. So mine has a UV, which is the primary measure of outdoor exposure, and along with that, it also has an accelerometer, an ambient temperature monitor, and putting all this together actually calculates the outdoor time using an algorithm which we have designed. So, thank you.
Thank you. We would like to call the next speaker now, Dr. Jitendra Nenumal Jethani. And the discussion for this topic, prism holding device, will be Dr. Anthrios. Can you take the mic, please, Jitendra? You can keep it there. Velmurugan, give it to me.
Thank you. So, good afternoon, everybody.
Mike.
Good afternoon, everybody. So, we all know that in India, we have a lot of patients who come to us late when they have strabismus. And most of these patients have very large angle strabismus. And the maximum prism that you have in your prism set, loose prism, is 50 prisms. So, if the angle is more than 50 prisms, what you have to do is you have to split the prisms on 2 eyes. That is the only way you can do it. So once you want to split the prisms, the problem faced is that you have to ask one of your assistants to hold the prisms. Now, when he holds the prisms, you need a person. You need him to put it in an exact plane as you want it to. It should be in the, so when you hold the prisms, these are plastic prisms. So you have to hold them in frontal position. You have to tell them repeatedly that you have to do like this, and only then you can do cover test. You can't put another plus 2.5 adapter if you want to measure AC by A ratio. You have to, if you want to add a vertical prism, you would need to tell that person to hold that also. So keeping these things in mind, we designed a simple device which we called prism holding device, or PHD. Now what it does is it has a simple central stick on which there is another mounted plate on which we have kept two holders. Now these two holders can move, and so this was the first prototype which we made in aluminium. But and then we went to steel and we made a lot of prototypes, but this is the final prototype which I have. So what we are basically doing is we are putting prisms in the two slots. Patient is holding the prism holding device. So examiners, both hands are free. I can take another 2.5 diopter lens, or I can take a vertical prism, or I can do, because now my both hands are free and patient is holding this particular whole device. So that basically you can bring it closer if you want to in a patient of large esotropia, and if there is exotropia, you can move it outside. So that is the simple thing. And this is just to show you how this particular final product is. This is a screw to tighten it. We can put a knob also as a finished product. So you can tighten it, you can move it outside, you can move it inside. So you can put vertical prisms also in this. You can put a vertical prism, or you can put a horizontal. This is a vertical prism. You can change it. You can put it horizontally. You can put it base in. You can put it base out. Whatever way you want to do it, it can be done. So essentially, it solves a simple problem, or rather a problem which we daily face when we have large angle strabismus. And so this is the.
Fantastic.
So is there any questions we can take?
Brilliant idea.
So it's a good presentation, but the prisms are available with a handle, but that is only single handle only.
Yeah.
This is a double.
So
Both are simultaneous.
So with a handle, there is no point. No, with a handle, so a lot of people, what they do is they tell the patient to hold the prism. So now the problem is, so when you do it, the patient will hold it like this, or he will hold it like this, or he will start doing like this. There is no stability on the prism. See, the amount of prism changes the moment you tilt it. You turn it like this, the amount of prism changes completely, because they have been calibrated that they have to be in the frontal position. If they are like this, the amount of prism increases, and if they are like this, the amount of prism decreases. So basically, you have to, with this thing, you can move it, you can tell the patient to hold the prisms.
But market also it is available with a prism with multiple prisms in the hand.
No. Nowhere in the world such a device.
No, not double, but single row.
See, putting a handle on this prism is as good as not putting a handle. You can hold it like this. Putting a handle doesn't change anything except that you are out of that axis. You can hold it like this.
Okay, anyway, it is good device, but it is a wooden. What's
right now, yeah, this is a wooden.
Wooden.
It's very sweet. Nice. For thick and thin prisms, does it hold equally well? Thicker and thinner prisms?
Yes. Because it is very big. We have made a very big footprint.
The thinner prisms are stable then?
Yes.
Thicker will easily set.
This is only 25, and this I have taken a 35 prism.
But the thickness will be different, but any prism can be fitted there?
Yes. 8 adapters, 4 adapters,
But even this one is patient only is holding.
Yes, sir. But patient cannot treat it like this. No, there's a tactile stimulus. This is, so we have, okay, I did not tell that. This is a square, mainly because patient should understand. If it is a circular, no, you will move it like this. So this is a square because of that only. We have thought of that.
Good idea. Good idea.
Very simple and
You need to make your knob much better.
Yeah, we are going to put another knob on the top of this so that it becomes bigger and it is easier.
The next speaker is
Okay, thank you.
Dr. Sanjay Chaudhary, and the discussant is going to be Dr. Ramesh Dorela.
Thank you, Dr. Chitra. So, the concept is just please stop the video. Stop the video for a minute, please. The concept is already there in the sense that if you have a PC rent, and you have residual nucleus, it becomes a dreaded complication for an anterior segment surgeon. The question is, how do you emulsify all that material which is lying there, and how do you prevent a drop in the vitreous? That means you have to go running to a retina surgeon. So far, the technology was an IOL scaffold popularized by Amar Agarwal, and it worked. It's been working for years. A lot of us have been using it. The concept is you put the same IOL which you're supposed to put in the eye, probably a 3-piece IOL. You put it there in the over the iris, get the nuclear pieces over it, emulsify it, and then put the IOL in the sulcus, and that's it. Now the problem was, if you put it over the iris and it is thick in the center, after all it's a convex lens, so your space in the AC reduces. Over that you have your nuclear pieces and you're emulsifying it with the phaco. So those nuclear pieces and the phaco energy is very close to the endothelium. Then you have to, after you've done that, you have to push it into the sulcus. So how do you have access to the epinucleus and the cortex? Of course, you take it out, but the process becomes difficult. So we thought, why not have something very thin, concave upwards on the iris, on which you can get those nuclear pieces and do the job. So here is one of those. Can I have the video, please? A nasty case, hard lens, brown you can see, PCR, vitreous, stained with triamcinolone. I put an anterior chamber maintainer, do the vitrectomy. Now, anterior chamber maintainer is a must because that maintains the chamber all the time. Both your hands are free to handle the complication. So you're virtually working with 3 hands. You pick up all those strands and cut with the vitrectomy. So once pick up one strand, all the strands will be pointing towards one of the ports. So you can easily identify them. Now this is a contact lens which is 13.5 millimeters. We cut it down to 9.5, and any injector, any IOL injector, under hydro, you inject it into the eye over the iris, get these nuclear pieces over the contact lens. Now, once it opens up, concavity up, now you have sufficient space to hold these nuclear pieces and emulsify them away from the endothelium. So now that I've got getting my pieces over this contact lens, remember the fear is always that this contact lens is very soft. It can sink into the vitreous. That fear is always there. So we use a bandage contact lens which is thicker in the center, 100 microns in the center, so it has a better consistency. And now I'm removing these nuclear pieces. There is no worry of any piece falling into the vitreous. Now there was this huge amount of epinuclear material. I went under the lens, got this epinuclear material out from the sides over the contact lens. At all this time, my anterior chamber maintainer is working. The IOP has to be low. The IOP should be just about 40 or 50. So either it is by a Centurion system or is it by a gravity fed system, it should be low, never over 90. The epinuclear thing gone. I'm very happy till this stage. Now I don't need this lens any further. Hold it with any forceps, bring it out. It just comes out very easily. And now I'm just left with the cortex as a challenge and some vitreous attached to the cortex. So I use a cutter, a vitrectomy cutter in the IA cut mode. Both my hands are still free. In the IA mode, I'm using it as an irrigation aspiration system. And as I bring it into the center, and if there's any vitreous strand also attached to it, in the cut mode, I remove this cortical material along with the vitreous strands. So I don't have to keep changing hands. First I do an IM mode, then I come out, bring the vitractor, cut the vitractor thread, then come back, do the IM mode. So just a vitractor is doing all those things. And see, without any pressure, without any tension, I get a very clean, tension-free cleanup. And once the cleanup is done, I'm putting the IOL again under hydro. I don't want to use visco here, but otherwise all that visco is going to fall into the vitreous cavity. So just put the IOL over the iris, then tuck it under the iris and do an optic capture. So a very dreaded complication kind of becomes very simple. Thank you so much.
Dr. Sanjay, magical hands you have. Superb surgery.
Thank you, sir.
So I would like to know whether you have dropped any of these BCLs into the vitreous.
No, fortunately, that was a worry. Was every time we thought that this is the possibility. So we used a 10 mm to make the size bigger so that it holds better on the iris. We used a 9 mm, but finally we decided that 9.5 is the best. But the key point is that the IOP should be low. If the IOP is high, the bottle height is high, there will be too much of pressure, and with that pressure it can sink down. There is the amount of pressure it can withstand in the eye.
So these are custom-made bandage contact lenses, is it?
These are normal bandage contact lenses which
They are
you can
usually
cut with a Trifine.
Oh, you're triffining them.
Yeah.
You're having time to have somebody get a BCL and to trifine them and,
Yeah.
and to supply it.
Now,
Amazing.
Now we have got them ready-made. We tied up with the contact lens company, and they are supplying us these lenses 9.5 size ready-made. So we have stock in our OT, and we have what is called the PCR kit. The PCR kit will have all these things: an ACM, a contact lens, a vitractor, everything that you need. A bottle to use to use with the ACM. So the moment you have a PC rent, stop. Put an anterior chamber maintainer, wait, observe, watch, and proceed.
So obviously you're a masterly surgeon who could do this, because I couldn't understand how you did an anterior vitrectomy and cleared the central zone, but the pieces didn't fall down, and you had time to inject the BCL inside. The exact process of injection I did not see, but you injected the BCL inside when the ACM is still pumping in fluid,
yeah,
and central vitrectomy had been done. So how exactly did the pieces stay there?
No, AC support. See, my question to you would be that how is it different from the HEMA hood that was described by K.K. Mehta more than a decade ago? And how is it different from the lens glide that has been used for anterior chamber lenses? They're predominantly the same thing. So that is the HEMA hood that he described was thicker, and it has a slightly larger diameter, and you could inject it the same way it is. So he called it the HEMA. It's the same material, HEMA hydroxyethyl method. So that has been described by K.K. Mehta more than 15 years ago.
Okay.
So the issue here is that until, of course, you have the anterior capsular axis, I think it will stay there. If the capsular axis anterior is not intact, it is, and then you have to take out the contact lens. If there is a nick in the anterior capsule, I don't think this should be propagated as something where you don't have a intact capsular axis. And I don't know why 9.5, because ultimately you are putting it in the sulcus. You might as well use 11 or 12 or something like that, because even an ICL is bigger than 9.5.
No, it doesn't open up very well. You know, it gets stuck to the side. It rubs against the endothelium.
So that is why a thicker HEMA hood would be a better thing, because which goes in, and then the only thing is getting it out. If it falls, is going to be much more tricky, I suppose. So that's
If it falls, yeah, we are lucky so far. We haven't had a fall, and we've done quite a few cases. It works well.
Dr. Chowdhury, you said it will give protection to endothelium. How it will give protection to endothelium?
Sorry, come again.
We'll call the next speaker now,
Next speaker.
Dr. Pratik Nishant.
And by the way, everybody has to stick to 4 minutes.
He will be talking on vectoral analysis of iris photographs for assessment of ocular torsion in cyclovertical strabismus, and the discussant will be Dr. Anthrios.
So good evening, everybody. This is my presentation, prospective comparative study to evaluate accuracy of vectorially analyzed iris photographs. Okay. So the diagnosis of torsional strabismus is not always straightforward. The current standard for quantitative assessment of cyclotorsion is the disc fovea angle on fundus photography. Recently, distinctive iris features are being used in various applications, and a need was felt to develop a simple, non-invasive tool so that you can measure the change in iris torsion using a consumer-grade DSLR camera equipment and personal computer software for capturing and analyzing iris photographs. Slide is not moving. Previous studies have entailed mydriasis, time delay, increased costs, inconvenience in uncooperative children, and in hazy media. This is the review of literature which describes the effect and the need for correction of head tilt and the changes in ocular torsion with surgery. The ocular torsion assessment using iris photography technique has previously been described by various foreign researchers. The lacuna is that there is paucity of binocular photographic studies, and none of them have been done in Indian eyes. There's need to develop a simple, low-cost, non-invasive technique and to test its accuracy. These are the objectives of this study. In particular, there is the need to develop the method of binocular iris photography using DSLR camera and to define the photography settings thereof. This was a one-year prospective comparative experimental study among subjects greater than 8 years of age with diagnosed cyclovertical strabismus. 30 eyes of 15 such patients were considered and pre- and post-operatively assessed for the difference in torsion formed using the two methods, iris and fundus photography. Photos were taken in a dark room with patient seated with erect spine. The face was perpendicular to the floor and parallel to the wall. Behind, the Frankfurt lines were parallel to the floor. The residual head tilt was corrected using the spirit level, and the camera was tripod mounted with lens level with the patient's eyes and two flashlights directed towards them from 45 degrees inferotemporally as seen in the figure. The equipment and settings were as shown. During photography, the head tilt was minimized, and these are the settings found out by empirical experimentation. Image analysis was done using CorelDRAW software, and the mathematical calculations were done in Microsoft Excel. We enhanced the images, marked the ellipses and iris landmarks, and the slopes of the line using joining the pupillary centers to the iris landmarks were calculated to get the iris torsion angle as an average of 4 iris landmarks. These are the demographic characteristics. Various diagnoses were considered, and both encyclotropia and excyclotropia were considered. These are the photos of two methods applied to one of the cases. Absolute fundus difference and iris difference were calculated, and the difference between the two methods was derived and expressed as a histogram. The distribution of the difference between the two methods was normal as determined by Gaussian kernels, QQ plots, and Shapiro-Wilk test. The mean difference was 0.15 degrees, and the two one-sided tests based on the wedge t-test showed the equivalence of the two methods. The method showed strong correlation using the Spearman's correlation coefficient 0.85, and Bland-Altman analysis also showed that most observations were within 95% limits of agreement. So binocular photography represents a more physiological state of cyclofusion. There's difficulty in which vectorally analyzing the iris pattern in dark irides, which has been analyzed and documented by previous researchers. In particular, Felius et al. Have conducted a previous study with only 4 eyes in Caucasian population, describing the use of a binocular iris photography. So this is the first study describing the camera settings for binocular iris photography in Indian eyes. Thank you.
Thank you, Doctor. Good study. But you are using a SLR camera.
Yes.
Then how you are taking a binocular photography?
Pardon, sir?
It is a single SLR camera.
One SLR camera, sir, seated with the photographer seated at a 50 centimeter distance from the subject, taking a temporal canthus to temporal canthus zoomed view of the patient with squint.
Oh, so both eyes will come in a
Yes,
single
sir.
shot.
Exactly, sir.
Then you are analyzing it with your own software, or it is some software?
The Corel software is commercially available, sir, and a new version is released every year. So the older versions are available without a license. The newer versions are available with a license. But then any version of the software, right from 7 up till say 19 going on now, any would do. And this is not the only software which can work. Photoshop also can work.
So what is your innovative idea in this?
My innovative idea is that, sir, the settings for photography have not been described in Indian eyes. So this particular method of binocular iris photography is my innovation, and all these settings are there for everyone to see and replicate, and in your own clinics, and to share the experience with us. So in particular, this binocular photography is important because the binocular state is a more physiologic state as compared to the monocular state. So with cyclofusion network, this is the only method that can give you a true picture of the cyclodeviation.
Okay.
Great. Thank you, sir.
Thank you, Doctor. The next presenter will be Dr. Prasanna Venkatesh, who will be talking on the 3D innovative holographic surgical stimulator, and the discussant will be Dr. Jyoti Shetty.
Good afternoon, respected dignitaries. Can I start? Yeah. Yes, sir. So this is a MIGS simulator that I'm going to be talking on, the one that we have done, the first generation. So this is a case of mine. You're seeing me placing the stent here. Everything seems to be going on well. And once the stent is placed, I'm just using the Helon, and you can see just the stent is just gone off. So there is a huge learning curve, my dear friends, at least for MIGS. What I have experienced is once the stent has just fallen off, I didn't panic. So this is microsurgery at a different level, especially when you view the direct gonioscopy. It's huge. Microsurgical levels are a bit huge. Then I went ahead and placed the second stent. Then I had to pick up the stent, as you can see. So now I've retrieved the other stent. We have 4 clicks in total. So I got a chance of retrieving it. But then I thought I'll close it and then take a breath and then go back in. But then it got caught in the cornea here. So this is one of my tricky cases in MIGS. But then I was able to retrieve the stent from the cornea. You can see here. And then I went ahead and placed this second generation eye stent. Then I had this, was able to place it here, and all's well ends well. So then it went on well. So but then this is just a video. What I wanted to show is in MIGS is very up and coming in India. So we wanted to go to the drawing board and make a simulator for MIGS, because MIGS was something that was falling in the blind spot. Cataract and phacoemulsification, SACS, where a lot of stents were being done. So we wanted to make sure that a learning curve is much fast forwarded. So this is a recent coding that we have done. You can see that when my friend here is moving his fingers in live, you can see that this is like a metaverse where that we have innovated on our own. It's a self-built product which is patented. So this particular technique of G1, especially G1 or G2, generation 2 eye stent inject. So you can see that he's catching the injector and he's going into the angle and he's placing the stent into the angle. So this hand-eye coordination, when he places it correctly, you can see that this turning into green in color. So we worked on this and we have developed this. So if he places it correctly, it turns green in color. So this hand-eye coordination has to be developed. And then when he does it and when he goes into a real time, he can work 50 times, 100 times, just like a pilot doing a simulation. This can be done. And then the simulation can be went ahead and placed. So this anxiety part can be taken care of, especially when you do the simulation. And there was no simulator till date for MIGS. So that is one of the novel innovations that we went ahead and we did. And we have also filed the patent, and we are also lucky to get this. So this, my dear friends, is the simulator that we have done. And we also did a short survey to study the difference between the wet lab training versus the surgical skill training. MIGS wet labs, if you see, they are very premature. It's still not ready, as I would say, if any one of you have taken the MIGS wet labbing. So the results are all promising. The hand-eye coordinations are much better. This is a very small sample size of 9 postgraduates from our center, but the results show that surgical simulator training, at least for MIGS, it's very well taken by the neophytes, and this seems to be the way forward. So this is a question. For want of time, I'm just forwarding the questionnaire. So surgical simulators does say that the mistakes may reduce, the complication may reduce. The accessibility of the simulator in the hospital itself is a big thumbs up. And for practicing surgical procedures without risking the patient, or at least 50 to 70%, you'll be knowing what is the structures that you're going to deal with, because with the simulator that we have one called the haptic sensation. So when you touch it, there is a small click. So that is why the 4D or the pseudo 4D that we like to call. So this is the metaverse that we have innovated, and we are trying to not only make teaching counseling, we have now upgraded to surgical simulation of not only one procedures, but welcome to the world of 4D metaverse, where we are trying to make all the surgical simulations for the benefit of the neophyte and the novice surgeons with real-time fundus, real-time angle images. So our images are all real, true confocal images which are not constructed. So this is the images that you see in the patient. So these are all real images with OCT filters can be done. Thank you.
it sort of went over my head. But what I would, as a glaucoma surgeon, also like to stress is more than this skill, what is needed is the direct gonioscopy skill when you're doing MIGS procedures.
ma'am.
Which I think is the biggest learning step for whoever wants to venture into it. There are many cataract surgeons also who do this because it's combined with cataract surgery, and they are not really they don't do that many gonioscopies
Yes,
as a
ma'am.
glaucoma surgeon would do, and vice versa is also true. Many of the glaucoma surgeons don't do as much cataract surgeries as the other do. So if you can incorporate the direct gonioscopy skills into this,
Yes, ma'am.
plus most of the times when you're doing the MIGS, the direct gonioscopy lens is self-retaining there. But you have to tilt it so many times because
Yes,
it
ma'am.
doesn't stay. So if you can incorporate anything of that into the training, it probably will be a complete module.
Yes, ma'am. Currently, we are working on the direct gonio lens, ma'am. And with iPrism SX, we have the self-retaining one. So that is one thing. And the second thing, why
But
we...
even that self-retaining is
Yeah.
not, it's not truly self-retaining.
Yes.
It's quite a lot.
Why we went the other way around was we felt the intraoperative. I mean, we want to make sure we innovate everything. So that's the end point that I'm seeing, ma'am. But why we went first we went into the eye rather than externalist. We wanted to make sure that the orientation inside the eye is also obtained. But we are working on the direct gonio.
Yeah.
Yes,
No,
ma'am.
no. Later discussions outside.
Yes, ma'am.
We have our next speaker, Dr. Ashish Pachau, and Dr. Purendra Basin is going to be the discussor.
Thank you, ma'am. Good afternoon, everyone, dear judges and panelists. Moving, continuing with where Prasanna left, it's about simulation, simulators, and simulation-based training. I am also involved heavily in simulation-based training for cataract, phaco, and very soon complications of cataract surgery. So simulation-based training it has been a game changer, as we all know, in microsurgical training, especially manual small incision cataract surgery. The system that we work on, which we have innovated, has a haptic feedback, so it makes real life surgical training possible. When you touch the tissues, they do feel almost 95% like real tissues whether you touch the sclera or the conjunctiva. The beauty of it is it's always an instructor led training, so there is somebody who will handhold you through, right from making the incisions to hydrating your wounds. A record for the performance is recorded for each attempt. You can go back, have a debrief session, and see where things went wrong. The idea is to practice more and more. You can do 100,000 attempts in a week's time until you can't get anything wrong. So that's the beauty of simulation-based training. It's definitely a game changer in cataract surgery. Today, we are now launching. We were training already on manual small incision cataract surgical training. Now, for AIOC, we are launching phacoemulsification. So my team, I'm the head behind the requirements, how it goes, how the tissue feels, whether it's a dynamic anterior chamber or a fixed anterior chamber, how much is the IOP loss, whether we are going in the correct angle for the incisions. There are these guiding tools which guides the trainee to make the perfect incisions. So not just incisions, we talk about capsular rhexis, whether we are using a cystitome or we are using a utrata, or we are interchangeably using a cystitome as well as a utrata. So the simulator supports everything. It has the tactile feedback where the tissue responds to you. The beauty in capsular rhexis is if you press too much on the capsule or the lens, it shows an alert saying that there was a zonular breakage of so and so much percentage. So it's a very intuitive feedback that comes real time. All the steps on phacoemulsification, right from capsular rhexis, hydrodissection, nucleus rotation, have been simulated. For the first product, which is the viable product, we have simulated divide and conquer. Now it also talks to you intuitively, saying that much is your depth. The foot pedal that you see on the left is something I reverse engineered from the various foot pedals available in the market. The probe, of course, it makes sounds in this presentation. It's muffled, but it does make sounds when it is occluding. It does make sounds when it is doing phacoemulsification. Now, all these are held by the instructor, as well as the guiding, where it tells the real-time position of the depth of the tips inside the anterior chamber, inside the capsular bag. So all these get recorded. All these have a weightage. There is a performance matrix which talks about how well you emulsified. Did you end up with some minor complications like contact to cornea or endothelium, or major ones? It talks about whether you had a posterior capsular rupture. All these things in a metric get recorded. So in a day, if you do 100 attempts, you already know when you start going for real life surgery, you already started a higher learning curve. Now this was already established in the study that we did on M6, that corroborated by Arvind and LVPI, that the complications came down almost as big as 40%. when the trainee started real life surgical training. So simulation based training definitely enhances skills, reduces complications, and gives better outcomes not only to you but to your patients as well. Post COVID, it has become the norm. It's a game changer now that we are launching FACO. In the end, everybody wants to see less complications. So there are happy surgeons, happy trainees, and happy patients. So I thank you for your attention and invite questions, please. Thank you.
Very good. So, discussant.
Sir, we started with SICS, then we started with complications. We already have insertion of a CTR manually, sphincterotomy and ACIOL implantation. For the conference, we are launching phacoemulsification. So phacoemulsification as a training product is already ready. A lot of thought has gone behind how much duration we should spend on training. So we have a phaco ebook that we have developed on our own, followed by classroom session. So it's typical 4-day session. We are partnered around with 50 institutes globally. In India, we are proud partners with Arvind and LV Prasad, and in Pune with D.Y. Patil.
What is the cost of the simulator? Sorry. What is the cost of the simulator?
Sir, they are not selling. We are not in the.
You're not selling.
We are not selling it. We are
You're just
subscribing
placing
the training. Yes, the course training.
How do you make your money?
Through the Robinhood model, where we charge around $5,000 in the US and subsidize cross-subsidized training in India and China.
For each resident?
For each resident, it's $5,000 in US and Europe.
Okay. India?
It's 200. That is 15,000 to 20,000 rupees.
Will it come into Vitreretina?
As we speak, sir, I'm launching anterior vitrectomy by the end of August, and the next step would be posterior segment. Yes.
So, how real it gives the feeling of a real like thing?
Sir, for established surgeons like all you are sitting here, you will take some time getting oriented to it. But for somebody who has had no experience on it, it is definitely giving them the hand-eye foot pedal coordination. It is giving them the feel of surgery. We did this comparative analysis between residents who underwent simulation-based training and then did live surgical training, and residents who did wet lab and underwent to do live surgical training. These guys had 40% less complications and they had higher skill rate. This is published in Nature 2020. So it definitely has that validity is proven. You start in a very higher learning curve.
You give a goggle kind of a thing,
Yes,
or
so we are
a
working
fixed microscope like thing.
We have a microscope based setup right now, but for screening and for short term courses, especially in this conference, we did introduce a goggle which is similar to Google goggles, but we have modified it on our own. We have a tech team which is transcontinental, and my team gives the requirements in terms of surgical training.
Ashish, very nice.
There is nothing, sir. It's pure AI. You don't see anything there, but when you see to the microscope and feel it, you feel a real eye operating on a real eye.
Okay, for paucity of time, we'll
When
move
you
on.
hold something, you get a grip of it.
You feel it. Yes.
You feel it.
Move on to the next speaker.
Thank you.
Thank you so much. We would like to invite Dr. Vivekanand VR, who will be speaking on managing ID repair, CTS and SFIOL the simple flanged way. And the discussion will be Dr. Harsh Bhattacharya, sir.
So good afternoon, everybody. So today I'll be. Shall I start now?
Please.
Yes. Yeah. Okay. So good afternoon, everybody.
No, you have to be louder.
Good afternoon, everybody. So today I will be showing two surgical techniques developed by me. One for iridodialysis repair and the other for scleral fixation of intraocular lens. So as we know, the conventional iridodialysis repair involves peritomy, making flaps or Hoffman's pockets. We're going to show a simple way. So this is a traumatic cataract with 4 clock hours of iridodialysis. So the iridodialysis is held at bay, and then rhexis is done and phacoemulsification is done safely. In this particular case, the bag was strong, so CTR was not required. We placed an intraocular lens in the bag. The viscoelastic, that is HPMC, was removed, and we used a combination of dispersive and cohesive viscoelastic to flatten the iris tissue. So using HPMC can roll the iris tissue, so it's very important that we use a combination of both to keep the iris flat. So the extent of iridodialysis is marked and the point of anchorage is identified. The conjunctiva is radially moved, and then using a spatulated needle attached to 7-0 proline suture, ab externo, the needle is introduced into the anterior chamber at the level of iris plane. So the peripheral iris is held with a microforceps. The needle pierces through the peripheral iris. The needle is exteriorized through the same phaco incision that we made. With the same needle, a U-turn is made. It is introduced into the anterior chamber. The second anchorage point at the peripheral iris is held using the microforceps and it is exteriorized ab interno route. So now we have a loop of suture inside the anterior chamber. So both the sutures coming out of the sclerotomy is pulled till proper approximation is achieved. The suture is trimmed and flanged using a portable cautery, proline being a material which melts at low temperature. A low temperature cautery is used. After the first flange, the second suture is pulled so as to bury the first flange below the conjunctiva and tenons. Once that is done, the second suture is trimmed to about 1.5 millimeters. It is trimmed, flanged and buried, and the conjunctiva is ironed out. As you can see, the flanges are much more anterior, whereas the conjunctival opening is posterior. So it's a simple technique where all you need is a spatulated needle that I designed for this particular procedure, and a portable low power cautery. So the advantages of this technique is no peritomy, it is easier, less time consuming, no scleral flaps or pockets. So this is the one-day post-op pictures and pre-op and post-op pictures of the ID repair. So we've so far done 8 cases in the last 2 years, and the results have been really amazing. We did not have any flange-related complications. So coming to the second technique, which is inspired by Yamane's flanging of the haptic and Canabrava's flanging of the suture, we came up with our own solution. So this is a long spatulated needle that we saw in the earlier case. So using the needle, sclerotomies are done 6 clock hours apart. It is exteriorized using a irrigating cannula as an AC maintainer. So we use a regular PMMA lens, be it a 3-piece or single-piece PMMA lens with dialing holes in it. The suture is passed from above to below, and it is trimmed and flanged. The size of the flange, till it becomes larger than the dialing hole, we flange it. The IOL is pushed inside the eye. The exteriorized sutures are trimmed, flanged and buried. So it is a very simple procedure. So after vitrectomy, all the time it would take to complete this procedure is probably 5 minutes till the end of surgery. So we've done over 300 surgeries. And this is what we do with the foldable intraocular lens. So this primary surgery has been done, and the conjunctiva is fibrous, so creating a tunnel was difficult. So using the same needle, we exteriorized through the clear corneal incision, and at the broad base of the optic-haptic junction of a single-piece intraocular lens, we pierced, we trimmed, flanged, loaded in a butterfly cartridge, injected into the eye. And similar fashion, the external sutures were trimmed, flanged and buried. Thank you very much.
Yeah, that is a novel idea. But
Sir.
I want to know what is the profile of your post-op complications and what is the pupil size?
Sir,
when you size and reaction to light after.
Yes. So initially we were doing this technique with a 26 gauge needle, sir. So in that we had 3 cases of vitreous hemorrhage which resolved within 1 month. And then we had corneal edema. Surprisingly, the incidence of iritis or any pigments in the anterior chamber is very, very less. Only due to the bleed from the tunnel area which enters, that was the main common problem. If it was done as a primary procedure like traumatic cataract extraction, anterior vitrectomy, esophageal, those cases had a little bit of corneal edema. Whereas clear-cut cases, mostly it was nice. So with the residents and fellows, initially people who are learning this technique, decentration was a problem. Because if the first flange, if you pull the suture a little bit more and flange it, the second, you cannot stretch the suture. It does not expand. So you will have mild decentration but no tilt. So that is one thing we've had. With the 26 gauge, we had 2 cases of flange dislocation inside the eye, so we had to repeat the entire process. So that was the reason why we came up with this idea of a spatulated needle, which is much more thinner. It is 200 microns, that is the dimension of the incision, 200 by 100, whereas a 26 gauge gives a dimension of around 400. It's a circular incision around 400 microns. So it is almost half, and the length of suture required for flanging initially was about 3 to 4 millimeters. Now it is 1 to 1.5 millimeters. Very minimal. So the main advantage of this is we do not see any elevation in the tear film with this needle and suture combination.
Thank you. Thank you.
Thank you, sir.
And Dr. Hemant Murthy is going to be the discussant.
All right, so good afternoon, and first of all, let me thank ARC for giving me a chance to present our technique of using fibrin glue in retinal detachment surgeries, a technique which allows us to obviate the use of oil or even gas tamponade. Now we know that the methods which we have for taking care of detachments are either a buckling or a vitrectomy or a pneumatic retinopexy. Over a period of time, our use of vitrectomy has become more and more, and these are some of the results of the practice and trend patterns, which have shown that more than 70% of surgeons for pseudophakic RDs, macula on inferior RDs also prefer doing a vitrectomy at this point of time. The problem with vitrectomy is that you end up using silicone oil or gas tamponade, and they come with their own set of problems. You need to give a post-operative positioning of at least 2 weeks for your patients. There is always a risk of glaucoma, corneal changes, cataract. There is a delayed visual recovery till the time you either remove oil or till the time the gas bubble gets dissipated. There is obviously a need of a repeat surgery because you need to remove oil inside the eye, and a restriction in air travel in case you have put gas inside the eye. And so we thought, can we use another agent to take care of these problems? So what does tamponade mean? Essentially, a tamponade agent is something which provides surface tension across breaks in order to prevent further fluid flow from going inside till the effect of a retinopexy, which is laser, becomes permanent. And we know that effect of retinopexy comes in something around 48 to 72 hours. So you need an agent which can provide a tamponade for around 72 hours till the effect of laser becomes permanent. And fibrin glue, which has been already used in ophthalmology in scleral fixated IOLs and ocular surface, is a very likely candidate. It has already been used in retina, in optic disc specific detachments and macular holes. We have studies which show that it is not toxic to the retina. Animal as well as human eye studies have shown it is non-toxic. So we have a non-toxic agent which can be used over here. And the technique is pretty simple. You do a vitrectomy, settle the retina, do a laser. But now after doing a laser, instead of putting oil or gas, put a drop of fibrin glue to cover the break. No post-operative positioning needs to be given. So this was one of our patients with an inferior detachment, and this is how the surgery is. You do an initial vitrectomy, and I just skip through some of the steps in the interest of time, but after completing a vitrectomy, you do a fluid air exchange, settle the retina. Subsequently to settling the retina, you do a laser around these breaks. And now after you have completed the laser now, at the end of completing of these laser, in a air-filled globe, what you do is you put a drop of fibrin glue to cover the break. A coagulum forms, and all that we need to do is just lift this coagulum and deposit it, and you need to just place it over the break so as to cover the break, and that's all you need to do. So you have a coagulum covering the break, and that's the end of the surgery. So this is how the patient is the first post-operative day. A vision of 20 by 100 and attached retina with the coagulum covering the break, and this coagulum gets completely gone away at 1 week. So imagine a retinal detachment patient with a complete visual recovery at 1 week without the need of post-operative positioning, without the need for using oil or gas. So now we have started using it for a lot of our patients, and these are first post-operative photographs of the same patient with an inferior detachment. This is how it evolves over a period of time. So our primary outcome was to see the successful anatomical attachment, and secondary outcome was visual acuity improvement at 1 week. So this is what we saw in our 50 patients, visual acuity improving to 20/80 at the end of the first week itself. So these are some of our patients, again pre-op and then post-op with an attached retina, glue gone away in a week's time. Another patient with inferior detachment, again at 1 week, attached retina, no glue inside the eye. One more patient, 2200 initially, first post-operative day, fibrin coagulum covering the break, and at 1 week nearly gone away. And we have now started exploring its use even in our tractional detachment RDs. So this was a patient, known case of SLE with a posterior break inferiorly, fibrin coagulum covering the break at first day in a fluid filled eye with a visual acuity of 20/50, and now at 1 week 20/25 vision, complete recovery, attached retina. So essentially, what does fibrin glue allow us? It allows us an absolute early post-operative recovery, no positioning for any of our patients, and no problems of conventional oil or gas tamponade. Thank you so much.
Thank you, Mudit. I know I've seen this, and you have a very nice presentation. What would be your limitations for this?
Yeah. So our limitations for this are, this is a surgery which works for early simple diagnostic detachments with breaks limited to 1 or 2 clock hours,
Correct.
even multiple breaks but within 1 to 2 clock hours.
Correct.
And one relative contraindication is a very large break. So if you have an extremely large break which is more than 2 to 3 disc diameters, that would be a relative contraindication, because what happens is that in those cases the fibrin glue can tend to migrate subretinally.
Yeah.
So
That's right.
extremely large breaks, number one. Multiple breaks in multiple quadrants is still a kind of a relative contraindication, but we have kind of now worked over it. So what we did was, in a patient with multiple breaks, we did one quadrant first, waited for 10 minutes, did the second quadrant, waited, and then did third quadrant, and that worked. But otherwise, one of the only relative contraindications is a very large break, and this will not work in old complicated RDs with extensive PVR.
Now, have you compared, let's say, these are all, let's say, in 1 or 2 clock hours. So scleral buckling would also work similarly.
Yeah.
So
sir,
when
this
you
is
compared, have you compared scleral buckling and this in their
so this is
functional outcome?
not a
Not
substitute for buckling. In cases which have got an extremely peripheral break where you can buckle, I would still advocate doing a buckling. So over here, fibrin glue is a substitute for a tamponade. For eyes where you are doing a vitrectomy and putting oil or gas, instead of putting oil or gas, now you can put fibrin glue and you will get away with the problems which you would have otherwise faced. But eyes which are buckleable, please go ahead with a buckle. That would be my advocacy.
very nice ideas. Thank you.
Thank you so much.
Thank you. Dr. Sunita is going to be our next speaker, and Dr. Manoj Mathur, you have to be the discussant, the cornea case.
Hello everyone. So I'll be presenting a modified technique of managing acute eye drops in large eye drops with a modified technique using compression sutures. Eye drops occurs due to a sudden split in the Descemet's membrane and the Duas layer, and there are several approaches of managing using conservative approach, intracameral gas
Get the mic
injection,
closer.
and full thickness compression sutures. Each have got their own disadvantage, and to circumvent that, we describe this technique of modified method of application of compression sutures, and this can be applied in large eye drops in three diverse case scenarios, which are keratoconus, pellucid, and trauma. So let us just see each of this. This is a case of keratoconus with non-resolving eye drops of 3 weeks duration, and this patient was developing neovessels in the cornea from the periphery. The sutures are applied. The suturing method is partial thickness, and in keratoconus, it is applied from the periphery to the center. An air bubble is injected in the anterior chamber to determine the level of the posterior membrane. In the central visual axis, infinity suture is taken to avoid through and through sutures through the stroma to avoid scarring in the postoperative period. Thereby, air bubble is released and a very minimal air bubble is retained in the anterior chamber, and we can see that intraoperative resolution of edema happening right thereon. So this is the post-1 day 1 picture, and the second picture is the post-op day 3, showing remarkable resolution in post-day 3. This is pellucid marginal corneal degeneration managed in a similar way. In pellucid, the rupture is crescentric to the limbus, and hence the sutures have to be applied in a radial fashion in a similar way. So this is the pre-op and the post-op same-day picture. This is a case of post-trauma in the case of thin cornea in a child, 8-year-old boy who presented with eye drops. In this case, we can see that there's a translucency, 360 degrees all throughout in the mid-periphery, and we can see on the OCT there's a breach in the posterior membrane, which is all throughout. This case was again managed in a similar way with compression sutures, taken 360 degrees, something very similar to PK, simply because the tear is all throughout in the mid-peripheral region. The sutures were past partial thickness, followed by burial of the sutures, and the air bubble which has been injected in the anterior chamber has been released at the end of the surgery and with an application of BCL through the conclusion of the procedure. So this is the post-op day 1 picture. We can see a remarkable resolution of the central corneal edema, and post-op day 1 week, the patient's visual acuity was restored to normal. Now, what are the differences compared to the prior techniques? The partial thickness sutures make suturing of the grossly edematous hydrops cornea way easier. The sutures act like draining ports, like venting incisions. Resolution of edema can be seen intraoperatively. Air bubble 100% is used, and bubbled size is less than 30% of the anterior chamber volume. This eliminates the risk of pupillary block and C3F8 and SF6 gas-related complications such as Urezevalia syndrome, cataract formation, pupillary block. This is not dependent on gas in the anterior chamber, so is effective in inferior breaks as well, and can be used in diverse indications. The various suturing patterns can be something like this. The guiding principle is to suture, take the sutures perpendicular to the tear if we can see it, as seen in the first picture. In other cases, it could be arcuate in the center area, infinity sutures, mattress sutures. All these can be applied in these various situations. Identifying the posterior tear becomes easier with using a light pep or an endo illuminator. The mechanism of quick resolution can be conceptualized based upon the external tamponade as is seen in buccal surgery for retinal detachment. The compression sutures brings the biomechanically weak cornea closer to the posterior defect, thereby facilitating the natural process of resolution. The outcome in 25 eyes with this technique is shown here. The recovery of edema from grade 3 to was very, very quick. There was a dramatic recovery, and from pachymetry, which is unrecordable, reached 593 by day 7. So this is the algorithm which I propose for the management of acute eye drops. It's not that every case has to be managed with compression sutures. The location, if it is periphery, like in pellucid, managed with compression sutures. If it is keratoconus case, where it is grade 1, grade 2, can you manage conservatively, and the grade 3 should be managed with the compression sutures. Thank you for your patient hearing.
So basically here you have to identify the location of the tear, isn't it? Sunita, yeah. Basically you have to identify the location of the tear and then decide the modality of suture. Or in case if you don't, if you are not able to visualize it, how to go about it. You will be putting the sutures all along, and then basically here air tamponade is the key, I feel.
Air tamponade is not really required, and it is just required at the time of surgery to determine the plane of the posterior membrane.
How does the Descemet's heal?
So Descemet's heals by just the compression effect from the sutures, which brings the cornea, anterior lamella, anterior part of the stroma, closer to the posterior defect, posterior membrane, and thereby the natural process facilitated. So you bring it compression sutures have to be really tight to match that level, and air bubble gives you that plane where your posterior membrane is. So once you achieve that, you can remove the air bubble or just leave a very minimal if you want to, and it is always air. It is not C3F8 or SF6, which are long-acting gases.
Would leaving a air bubble inside will not help your
Actually, this is air bubble is not really required because it can cause problems. This is just to circumvent all those problems with the earlier procedures.
All of you totally on marks.
Because your point of creating multiple vents by these sutures is well taken. You can see the effect right on the table. That's well taken. Nice presentation, Sunita.
Thank you, sir.
Thank you. We shall go on to our last speaker, Dr. Vivek Veerwal
Dr.
and Vikas. And I call upon Dr. Mahipal to do
Thank you, everyone. A very good afternoon. I'm very happy to present a new technique on double anterior single posterior delineation technique with the release sign. So, as we all know, smile incision, smile marks a paradigm shift from flap-based LASIK procedures to flapless refractive surgery. But it has a steep learning curve, and the surgical outcomes, especially in novice surgeons, can be unpredictable because of the misdissection of the lenticule that can result in poor surgical outcomes for the patient and nightmares for the surgeon. So in a conventional smile surgery, the delineation that is done for the anterior and posterior plane is on the two sides, one on the right side and one for the left eye, one for anterior plane and one for the posterior plane. Now this often leads to misidentification of the planes, resulting in the unintended initial posterior plane dissection, causing cap lenticular adhesion and difficulty in extracting the lenticule out. So to circumvent this and overcome this, we present the DASP delineation technique with a novel release sign. So in this technique, what we have proposed is that we use two areas of anterior delineation on the sides, and the center area is for the posterior delineation. And the maneuver for entering the anterior and posterior planes is different. So for the anterior plane, you can see by the red arrows that the dissector enters first between the edge, between the lenticule edge and the cap edge, as you can see in the video here, and then it is moved inwards curvilinearly towards the anterior plane. Because the anterior plane is in continuation with the undersurface of the cap, with this maneuver, it's highly unlikely that you will enter the posterior plane in the delineation component. So on the two sides of 1 mm, you do the anterior plane delineation. When you do the posterior plane delineation, you enter head on with slight posterior pressure on the cornea. And when you are doing the posterior plane delineation, as has been described previously, was the stop sign. Here we describe a double stop sign because you have two areas of anterior delineation. On both the edges, you will feel resistance to the movement of the dissector, giving you double assurance that both the initial sides were of anterior delineation and the central period is of the posterior delineation. Now, what this also tells you is that if you don't feel the stop sign on one of the sides, that means that area probably was not anterior delineated. Okay, so it gives you a caution there. Beyond this, when we start the dissection, you start from one of the sides of the anterior plane. And here, as you move across towards the central area to the previously other anterior delineated area, you feel a sudden release of the resistance that you are feeling with the dissector. Because the other area has already been delineated, once you reach it, as you will see here in the video, very clearly you will feel a sudden release of resistance. So just give it a second, and here. So you saw the release sign. This is what we call the release sign. If it again gives a reconfirmation to the surgeon that you are doing anterior plane dissection. Now there is no release sign which is felt when you do the posterior plane dissection, because there is only one area of posterior delineation that has been done. So rest of the procedure is completely routinely. Now, as a novice surgeon with less than 5 cases of experience, when we did this surgery in more than 60 cases, there was no case of missed dissection that happened. The advantages of our technique is that it's very simple, reproducible, and very easy to adapt even by novice surgeons. It's equally safe even in low myopia patients where dissection can be challenging. And it also gives an opportunity to rescue in case you dissect the posterior plane first. But the biggest advantage is the multiple checkpoints that it provides to the surgeon during the surgery. First checkpoint being the differential entry maneuver for anterior and posterior plane delineation. The second being the double stop sign. And the third being the release sign. So rest assured, if you follow the DSP delineation technique, both the surgeon and the patient are going to walk out with a big smile on their faces after every smile surgery.
Thank you. Discussion, we keep it short and brief, Dr. Mahipal.
So because I think good that you have described it more scientifically, and I can't fault you on that. Yes, it just gives you the added comfort. But typically we are just working with the stop sign as we have, and maybe might take a little more time. But otherwise, I think it's a good thing for a learner. That's about it. Good.
Thank you.
Thank you very much, judges, for being there, and all the speakers for your terrific presentation. We'll just take one very brief photograph, because then after that is on your march, get set, go. 4:30, the